Thank you, Dr. Gabrielson, for that very kind introduction. I'd like to say thank you to the department as well for allowing me to speak today and for the assistance that I've received in the creation of this talk. I have no disclosures for today. One of the concepts that I wanted to discuss today as I was looking at trauma systems, this is a topic that I developed an interest in as I was interviewing and seeing the efficacy of our trauma system as we take care of patients in the state of Delaware. I was trying to think of an analogy for how we develop the care of the trauma patient in our system itself, and I sort of lit on an experience that I had when I was in Boy Scouts back in high school. So I actually had the opportunity to participate in some shooting sports. I participated in clay pigeon shooting, and it's actually very hard to do. You actually have to maintain your sights on the target as it moves across your field of vision. You have to lead the target slightly to be able to maintain focus on it, and you actually have to make sure that you're maintaining a distance on the target so that you hit it accurately. When I was in medical school, I actually had the opportunity to participate in trap shooting with my roommate, and that's even harder. You actually cycle through on this concrete pad through a system as the house shoots targets at different degrees, and you have to make sure that you're aiming accurately. The target actually moves in 3 different dimensions, and I think this illustrates nicely the concept of trauma systems. You're actually trying to hit a moving target. You're trying to accurately assess where the trauma system is moving. You're trying to make sure that you are understanding all the components that are integrated into the care of the trauma patient. And that's the analogy I want to leave you with as we start this talk today. I'm going to discuss with you the history of trauma care, the design and implementation of a trauma system itself, including the components of that, as well as the system design in and of itself. I will talk briefly about the validation of a trauma system in terms of the patient care and the system impact, as well as some of the challenges associated with trauma systems today. I will spend some time focusing on Delaware's inclusive trauma system as developed by Dr. Tinkoff and a lot of the other faculty here at Christiana Care, and then some of the future directions in trauma care for our system as well as in the country itself. Just a quote from James Baldwin, I think, in order to understand the components of what goes into the system of trauma care, you have to understand the history of it. The history of trauma care actually predates recorded history. In 10,000 BC, as early as 10,000 BC, they've noted in multiple areas across the world evidence of trepanation of the skull as well as fracture treatment. This was actually performed by priests and shamans, and they've actually shown that there's evidence that this could even be performed on patients more than once, as some healing is noted in some of the specimens. Looking forward to ancient Samaria, we actually find the first evidence of recorded history of trauma care. Interestingly, if you look at their recording, most of it's circled around wounds, and they comment on 2 different types of wounds. The first is wounds that were survivable, and the second is those that were not. And I think this illustrates that we as surgeons tend to publish the obvious at times. There's also the first evidence of litigation in the early world, as physicians were only held responsible when they used the knife. And I think you can see that the lawyers had hold of us very early. As we move forward to ancient Egypt, different historical findings show that the ancient Egyptians were fairly adept at using different types of therapies for wounds. They would actually use thorns or stitches for different types of wounds. They were useful using cautery for wound control and hemorrhage control. They would use opium from poppies for pain control and actually had a system for fracture stabilization as well. Looking forward to ancient Greece, we actually find evidence of the first trauma system. So the ancient Greeks would actually triage their wounded to Greek barracks called Clysiae. In addition to that, they would also triage them to local nearby ships, and I think this illustrates the concept that they understood that trauma care had to be close to the area of injury for the best outcome. Even with that, if you look at Homer's Iliad, there were 147 recorded wounds with a mortality rate of 77.6%. So even still, they weren't able to impact the mortality of their trauma patients in a great impact. One of their problems with this was the concept of the 4 humors, and that actually deranged how they managed their trauma patients. One of the things that they had very wrong was the concept that hemorrhage kills but bleeding helps. They would actually open up a vein proximal to an area of injury to try and help hemorrhage. And as we all well know, bleeding a wound is not going to make the bleeding better. This was actually in relationship to, as well, the tourniquet use. And Scribonius Largus was a historical scientist in ancient Greece, he actually tied a tourniquet around a skin bag and actually noted that more fluid was forced from the wound. And as a consequence, the ancient Greeks condemned the use of the tourniquet, and we have them to thank for having to work through that science again in the last couple millennia. There was an idea of exchange of medical concepts across cultures. The Chinese had actually used ephedra fairly effectively for hemorrhage control and wounds, and we saw that exchange to ancient Greece and Rome across the Silk Road. So there was a sharing of ideas and knowledge in this, akin to what we do today between the military and civilian trauma systems. Moving forward to India, we actually find a fairly well-developed trauma system. In the reign of Ashoka III, there's actually evidence in the book, The Art of Shastra, of a very well-defined ambulance system, as well as a system of well-trained surgeons and even women that traveled along with the army. They actually worked to prepare food and drink for the wounded, as well as to perform bandaging of wounds. This is actually the first recorded evidence of treatment by a surgical specialist, and you can see the Shalyahara were the surgical specialists of the army. They were actually translated as arrow removers, and that was their specific job, and they had a very complex system for how to do this. In ancient Rome, we find evidence of surgical concepts. Celsus was noted for talking about hemorrhage control by pressure. He would actually place lint in a wound and hold pressure, and if that didn't work, he would repeat that again with lint soaked in vinegar. If all else failed, he would comment that the veins that are pouring out blood are to be seized, and around the wounded spot, they are to be tied in two places. So we actually find the concept of ligature control of bleeding at this point in time. Ancient Rome was also notable for having a system of wound barracks as well, called the valetudinaria. These were quarters for the sick and wounded, funded by the Roman generals, and they were actually found throughout the empire in as many as 25 historical locations, all throughout the extent of the Roman Empire at that time. There are actually, as noted as well, 85 Roman surgeons by epitaph all throughout this time as well. So they had a very well-established trauma care system. All of this history actually illustrates that even though the ancient worlds had an understanding of the ideal care of the wounded, it was not idealized. They did understand that transport time was associated with morbidity and mortality, that there was a triage method necessary for the care of the wounded, and that the optimal care of the injured patient should be by someone skilled in the care of wounds. But further work would be done about 1,800 years later. Dominique Jean Leray was the surgeon-in-chief to Napoleon. He's actually credited with the foundation of the trauma system as it started. He would standardize the triage of casualties based on the severity of the injuries and the urgency of need for medical care, and this was done regardless of rank or nationality. He's also credited with treating enemy soldiers. Part of the system that he used was called flying ambulances. Napoleon used a system of flying artillery on the field of battle to try and move his artillery as quickly as possible. This was adapted by Leray to try and move treatment across the battlefield to the area where necessary. His units had to be mobile, and this actually became the precursor to our modern MASH units, and helped to improve outcomes for the patients by rapid triage as well as rapid definitive care. Moving forward, we can see a lot of the advancements made in trauma care in the U.S. Advanced through practices performed in wartime. In the U.S. Civil War, we actually find the introduction of antisepsis techniques. This actually predates Lister's use of carbolic acid. We find that antisepsis techniques would actually have a major impact on morbidity and mortality of trauma patients, and this is extended throughout the course of the wars in the 19th and 20th centuries. They also would popularize healing by secondary intention, and this is when they started to utilize nursing care more actively in the care of the trauma patient. This was done by Clara Barton, and this was an extension of the work done by Florence Nightingale in the Crimean War. Here you can see that people who died of wounds would improve throughout the course of time from the American Civil War all the way through Vietnam, and we had a very high impact through the use of antisepsis techniques. Moving on to World War I, I'd like to thank Dr. Braverman for his very enlightening talk about whole blood transfusion, and that was one of the major impacts on trauma care by physicians at that time. They also would move forward from healing by secondary intention to a delayed primary closure after wound debridement. In addition, motorized ambulances were actually introduced at this time. The problem with ambulance control in World War I was that there would often be significant delays, and they actually found that care for the trauma patient would be delayed by 12 to 24 hours. The other big contribution from World War I was the concept of shock. Up until this point, the concept of shock was fairly nebulous. It's noted that John Warren in the 18th century said that shock is a momentary pause in the act of death. This would be disputed by Walter Cannon, who described wound shock in the time frame of World War I. And he actually commented on the concept of septic shock as it relates to trauma care. And this actually would transform trauma care in the concept of sepsis. We can see transformation of trauma care in the United States on a civilian level starting in 1912. The American Surgical Association met in Montreal, and a committee of 5 was actually appointed to prepare a statement on the treatment of fractures in the United States. In 1913, the American College of Surgeons was formed, and in 1922, the Committee on Fractures was created. Charles L. Scudder became the first chairman of this, which would eventually become the Committee on Trauma in 1949. Furthermore, the Hospital Standardization Program was created. This was eventually the Joint Commission. In combination with the Committee on Fractures, as well as several other boards of medicine in the United States, we eventually would have the Primitive Trauma Database as they collected data on traumatic fractures. Moving forward into World War II, we see the discovery of antibiotics having a major impact on wound sepsis and the use of penicillin. We also found that improved transport times through a dedicated ambulance service would actually impact transport time for definitive care, about 4 to 6 hours, as opposed to the significant delays in World War I. However, unfortunately, we were unable to learn definitively from the lessons in World War I, and they struggled with treatment and resuscitation and shock, as well as the use of a blood bank. A lot of this was transformed in World War II for transport time by the use of helicopters. The wide use of helicopters in the Korean War, actually improved transport times down to 2 to 4 hours. Extended through the Vietnam War, we actually found that the time to triage was actually declined down to 1 hour, and this had a significant impact on the mortality of trauma patients in wars. Furthermore, the use of MASH units also cut down transport times by putting the hospital as close to the forward operating position as possible. In addition, different surgical techniques such as arterial revascularization would make trauma care and limb salvage increasingly efficacious. As we see, military advancements would continue to drive improvements in the care of the injured soldier. However, here in the United States, we found that the trauma care was abysmally behind in relation to our military partners. That sparked a report by the National Academy of Sciences in 1966. A couple of statistics at that time. They found that there were 52 million injuries in the United States in 1965. The mortality of these injuries was 107,000. This was associated with a temporary disability in 10 million people and a permanent disability in 400,000. The ultimate cost to society at that time was $18 billion. The National Academy of Sciences actually had several incentives with this. They called for the development of a National Trauma Association. They wanted a standardized and systematic care for an injured patient, as well as an emergency medical systems categorization and accreditation process. They called for education of the public of the public health issue that was trauma care, as well as a call for preventative strategies for injury prevention. And they also commented on a dedicated research curriculum toward trauma as well. One of the important concepts from this report actually was the idea of trauma care as a political issue. They wanted to stress the concept that trauma is a public health entity and that we need to be concerned about this from a legislative process as well as a local process and a healthcare process. As a consequence of that, the National Highway Safety Act in 1966 authorized the Department of Transportation to give authority, money, and instruction to implement law. They wanted coordination, transportation, and communication as necessary to bring the injured person to definitive medical care in the shortest practical time. This actually funded an ambulance service in the United States. And 2 different hospitals at that time were credited with becoming the first trauma centers. The first is San Francisco General Hospital under the leadership of William Blaisdell. And the second was Cook County Hospital under the leadership of Dr. Robert Freark. A little closer to home, we actually see the development of the system in Maryland. R.A. Cowley was credited with the establishment of the first statewide trauma system. This was done at the University of Maryland. He actually coordinated the Maryland Institute of Emergency Medicine, the University of Maryland Hospital, as well as the police department. The concept was that the police would transport patients by helicopter from the site of injury to the institution with dual goals. The first was rapid evacuation, and the second was the timely treatment of shock. Again, this was the first established statewide trauma system, and the implementation of this trauma system is associated with a significant decrease in mortality that I will go over a little bit later. Illinois followed closely after that. In 1971, they actually developed a political activity under the authority of the state government with the participation of the governor. They had 5 components in their trauma system. The first was categorization of hospitals as trauma centers. They then looked at technology to promote instantaneous communication between field transport and hospital providers. They looked at ambulance design to optimize triage. They looked at special training of healthcare professionals to optimally provide care to the injured patient. And finally, they had a program for evaluation of care within their hospital system. As you can see, all of this is coming together to create the modern trauma system that we have today. A couple of different trauma systems then sort of develop under the leadership of systems in Maryland, Illinois, and Florida. And they actually spurred funding from the federal government for further trauma system development. The Emergency Medical Services Act in 1973 was implemented, and this actually gave grants to states under the local government or other regional arrangements. This actually called for further EMS providers to allow for care in rural or other medically underserved areas. Under the next course of 8 years, $300 million was assessed to these trauma systems and actually spurred 304 different EMS regions to be developed. As a consequence, we saw an impact in trauma care throughout the United States. Moving forward, the ACS Committee on Trauma released their document, The Optimal Hospital Resources for the Care of the Seriously Injured. This was done in 1976. This was emphasis on the operation of trauma care within a system of care. This was further tweaked in 1978 as a consequence of the experiences of Dr. Jim Steiner. Dr. Steiner was an orthopedic surgeon who was flying his plane over rural Nebraska when he suffered a crash. His wife was killed instantaneously. Several of his children were critically injured as well as himself. And he received such poor care at a rural hospital in Nebraska that he pushed for both legislation as well as political action to develop a system of care for trauma patients, and this later became the Advanced Trauma Life Support course. This was released by the ACS Committee on Trauma in 1980, and it's still the system that we use today for the care of our trauma patients. Another concept along with this was trauma care as it relates to public health response. In California in 1980s, there was a document that was released by West et al. He actually commented on disparities in care between the San Francisco General Hospital System and Orange County. They looked at TBI patients and found disparate outcomes. 2/3 of their patients in Orange County died of possibly or frankly preventable deaths. As a consequence of the public outcry to this disparate care, a level 1 trauma center as well as 4 level 2 trauma centers were created secondary to this. And they actually found that there was a reduction in preventable deaths secondary to that, and I'll go over the papers for this later. Another concept that became very popular around this time was introduced by Trunke in 1983, and this was the concept of the golden hour of trauma care. You can see that 1 hour we gain the ability to impact trauma care for these types of patients with serious injury. And this spurs the idea that rapid triage and rapid transport to definitive care is an important modality for reducing morbidity and mortality of our trauma patients. These concepts of trauma care were extended to San Diego and to Portland for further trauma system development. Finally, after the 1966 report, another report was issued called Injury in America by the federal government. This was a 20-year follow-up to the analysis. They actually found that despite considerable funding towards the development of trauma systems, there had been little progress made toward the reduction of the burden of injury. As a consequence of this, the Center for Injury Control was developed as part of the Centers for Disease Control. There was research into prevention, pre-hospital care, acute care, as well as rehabilitation for acute injury. And this spurred a lot of the research that we see today. We're going to move forward into the design system components of trauma care. In 1990, the federal government released the Trauma Systems Planning and Development Act. Under this, there was a contingent of the plan to develop a system for individual states, and this was an impetus by Reagan in 1986 for a statewide trauma plan. They found that the federal government had been ineffective at impacting trauma care, and they turned the impetus over to the individual states. In 1987, the ACS established a trauma center verification program, and this is the first location that we see the concept of an inclusive trauma system. Up until this point, many injured persons had been neglected that had minor or moderate injuries under the exclusive trauma system that had been developed. We find this replaced by an integrated approach to patients in all injury categories and a systems-based approach to include all hospitals within the trauma system itself. And this is extended into our concept of an inclusive trauma system today, both one that we use in this state as well as used in the remainder of the country. The concept is that trauma care should be community-based rather than a trauma center-based, and there should be plans for all populations incorporating the unique needs of the society and the region in that area. The design components that they talk about are multiple, and I'm going to talk about each one of them. The first is the concept of leadership. So a state lead agency was one of the important concepts they talked about, and this should be a lead agency that works with medical and professional societies and was ultimately responsible for coordinating the trauma system design. They were needed to establish a minimum standard of system performance and patient care, and they wanted a medical director for this particular leadership organization. Moving forward into system development, there was a concept of having a system that would determine the magnitude of injury within the community, as well as to document the level of resources available. This is also extended into the trauma database, which was established in 1989 under the ACS Committee on Trauma, and they wanted research using the National Trauma Database to develop the system specific to the unique regional needs. Next comment is on legislation, and they wanted an inclusive model and a broad-based design, and they wanted comprehensive legislation that addressed the responsibility and authority necessary for this implementation. It's a very nebulous concept, but something that becomes important as we look at the development of our own trauma system here in Delaware. They do comment on finance, and they made several comments that you should have a dedicated system of trauma funds. They looked at several ways of accomplishing this, such as taxes on cigarettes or alcohol. They looked at surcharges for telephones or vehicle registration, as well as traffic violation penalties, but ultimately they did not comment on a system for federal funding nor for any ongoing system for this, just that you should have a plan for it. They also wanted to establish a positive cost-benefit analysis. And we'll see the concept of funding as it relates to the development of trauma system care. The next concept is for public information, education, and prevention, and they wanted to underscore and stress the concept that this is a preventable public health problem. They wanted to engage community sectors, such as policing, fire agencies, highway safety agencies, as well as health and auto insurance, as well as alcohol and drug abuse groups to try and impact the burden of traumatic disease in the U.S. And they also wanted to use persuasion programs as well as legislative or enforcement programs to try and impact trauma care throughout the United States. Human resources were also important, and you wanted education and training of personnel in sufficient numbers, both on EMS, nursing, ED providers, as well as trauma surgeons. And the use of technology could be used to extend this to the rural sector as well. Under pre-hospital care, they commented on 4 different areas: communication, medical direction, triage, and transport. They wanted to make sure that there was a system of care outside of the hospital in the pre-hospital setting, and to make sure that this was high quality and cost-effective care. This was done through adequate communication between the hospital providers and the pre-hospital providers, and a system of rapid triage and transport to a definitive healthcare setting. Looking forward to definitive care facilities, they commented on 3 different areas: both the trauma facilities in and of themselves, inter-facility transfer, and rehabilitation. The ACS Committee on Trauma had again extended the level determination for trauma centers, and they wanted integration of all the facilities in an inclusive system, and that's the network of definitive care to provide the spectrum of care to everyone. The lead organization for this at the trauma facilities level was to be the Level 1 Trauma Center, and that had a distinct leadership role that they commented on. They wanted to make sure that the Level 1 facility had resources to support this full spectrum of injury, from providers to technology to the actual facilities themselves. They wanted a comprehensive medical rehab program. They wanted teaching and research commitment from those organizations to the full care of the trauma patient. And they wanted an education and systems development performed through leadership. They also commented again on interfacility transfer and a feedback mechanism to make sure that the facilities at lower levels were appropriately triaging patients to a higher level of care, and the concept of medical rehab to integrate these patients back into society after they had completed their definitive care. The final step of this was evaluation, looking at data collection, systems evaluation in and of itself, and research. They wanted to make sure that quality management was performed through programs with a multidisciplinary approach and a peer review process. And they also, this extends to the data collection on a trauma database standpoint to make sure that we are accurately caring for our trauma patients. Ultimately, you can see this extends to the public health model released in 2014 by the ACS Committee on Trauma. This is evaluation of a trauma system as a model of public health. This starts on the level of assessment, and the assessment is performed on a systems basis. You want systematic collection and analysis of injury-related information and the resources for care. They should describe the injury problem and identify potential opportunities for intervention. This is extended toward policy development, done at both a legislative and a local policy level, for comprehensive policies and standards of care, driven by the assessment to meet the goals of the trauma system and to improve the outcomes of the trauma patient. This was done by collaboration and through educating both elected officials and empowering stakeholders for this. The assurance portion is designed to make sure that we are accurately performing and assessing our duties as trauma care providers. Implementation, monitoring, and evaluation of system components was performed, and adherence to the policies and standards of care and enforcement of these policies to make sure that we are caring for our patients in an optimal fashion. Ultimately, what we're looking for is the seamless transition between the components of a trauma system, and the goal being to reduce the morbidity and mortality of those involved in the care of the trauma system itself. So we see some themes emerging at this point. The first is that trauma is a public health issue which accounts for a significant morbidity and mortality. The optimal care of the injured patient requires an integrated and inclusive system designed around the unique needs of a particular region. And the implementation of a successful trauma system requires leadership and coordination of all governmental, healthcare, and community resources. I think ultimately we've been given the tools to accomplish some incredible and amazing things to the betterment of our patients and our community. And we need to take every and full advantage of our situation to do so. Perhaps the burden of traumatic disease is under-realized in this talk up to this point, so I'm going to make a couple comments about the epidemiology of trauma. If you look from 2012, some census data on the 5 leading causes of death in the United States, you see that trauma is listed 5th in the number of deaths total. However, this potentially impacts the burden of disease. When you compare the average age of the victims for each of these individual causes, the average age in the first 4 categories is in the 7th decade of life. The average age of the trauma patient is 45. If you look at the years of life, potential life loss in that regard, you can see that trauma jumps to the 3rd category. Looking at it from a different perspective, you see the total burden of cost from this is on the order of $820 billion as of 2013. I'm not trying to pick on our cancer care or heart disease care. We need both of these concepts as well. However, AHRQ estimates that cancer care costs in the U.S. in 2014 were $87.8 billion. This is an order of magnitude of 10 less than the cost of trauma care in the United States. Looking by 2030, it's estimated that $818 billion will be spent on cardiovascular care in the United States. If we can impact trauma care in the U.S. for 0 deaths and 0 morbidity from this, we would actually be able to pay for cardiovascular care in the U.S. with all the money saved. The validation of trauma patients or trauma care systems to this point was driven largely by small studies. We see a significant impact, however. One of the studies I commented on out of Orange County in San Francisco found a reduction in preventable death rates from 40% in a non-trauma care system to 1% in a trauma system itself. This was reiterated by preventable death reductions both by Shackford and Kreis in the San Diego and Florida systems, and we see the impact this has had on a smaller level. However, the systems themselves weren't really evaluated in a full function until this study. This is the National Study on the Costs and Outcomes of Trauma Systems. This was a matched cohort study of 18 Level 1 trauma centers and 51 non-trauma centers. They looked at outcomes at 30 days, 90 days, and 1 year total. And they actually found a lower risk of mortality in Level 1 centers with a statistical significance, 10.4% versus 13.8% in the non-trauma centers. They found a couple of other things, that non-trauma centers treated more elderly patients with comorbidities, and that trauma centers treated more young and severely injured patients. This is borne out in their data that they published. They also found that trauma systems themselves had a better impact on more seriously injured patients for AIS scores of greater than 4. Moving forward, we see other studies. This is out of 2006 in the Annals of Surgery. This was evaluation of a mature trauma system in the state of Florida. They found that treatment of the trauma care system was associated with an 18% reduction in mortality. They also commented on the cost of care with this. They found that trauma care systems operated at $11,900 for the care of the injured patient, and that non-trauma care systems had a cost of about $6,000. If you crunch the numbers, they actually found that the cost of trauma care was about $34,000 per life saved, showing that trauma systems, although effective, are not necessarily cheap. Moving forward with this, we find the next study out of that Rotondo published in 2009. He looked at his trauma system 5 years before implementation of a level 1 trauma center, and then 5 years post-implementation. They actually found an increased ISS and increased admissions for their patients, as well as a reduction in length of stay and mortality for severely injured patients greater than ISS scores greater than 16. If you crunch the numbers for their study, they actually found a total of 173 lives saved. However, the direct personnel costs that they experienced were $7.6 million pre-implementation, which came up to $22.7 million post-implementation. Again, underscoring that there is a cost associated with a trauma care system. Again, I will show you that that cost isn't necessarily mitigated by legislative factors for funding for trauma care systems. The cost of a life saved that they found was approximately $87,000. Moving forward, we look at follow-up from that NSCOT study, and they actually confirmed the cost-effectiveness of trauma care within a level 1 trauma center. They found that the cost in quality-adjusted life years of trauma care was $36,000. If you compare this to the cost-effectiveness of renal dialysis on the order of $50,000 to $100,000, you find that trauma care is actually very effective, but again, it just has a significant cost associated with it. Follow-up in a study in Arkansas that was done in 2015, they actually found that trauma systems operated at about $1,600 at level 1 and level 2 for the trauma centers, and then level 3 and level 4 is operated significantly below that at $450. They found that lower-level trauma centers actually referred their very sick patients, and this actually improved their margins for the hospital system itself. One of the other interesting comments that they made was that if the hospitals at lower levels were to drop out of the trauma system, it actually had a worsened impact financially on the higher-level systems as they would take care of these trauma patients. This shows that the cost associated with trauma care becomes important in how we take care of these patients, as well as the fact that if we don't have a method of funding, we can go bankrupt in these hospitals. This is underscored by some of the legislative efforts. In 1981, the Omnibus Budget Reconciliation Act actually pulled trauma systems funding from the federal government, and many EMS management organizations lost funding and closed in the United States. They tried to re-implement funding for trauma care systems in 1990. However, Congress failed to reauthorize funding in 1995, so the federal government could not maintain an adequate level of funding for trauma systems. In 1992, an experience in LA County and USC found that the level 1 trauma center for care of that population was actually facing bankruptcy. President Clinton actually had to bail out the hospital system so they could maintain their trauma system open to take care of their patients. This is underscored by the lack of federal and state funding for trauma care systems. There are actually only 43 states that have some type of federal funding for trauma based on the 2012 National Conference of State Legislatures. You can see as well that state funding for trauma is missing in several states that have a very high level of trauma care. EMS funding is also significantly lacking for these areas as well, and you can see that many states also have no funding for EMS providers. Moving forward, we look at disparities in access to care. A study out of Journal of Trauma in 2004 found that 36% of patients with major trauma actually received care at at centers that were not designated for trauma care. They found that the availability of trauma centers varied greatly across states and actually ranged from 0.9 to 6.6 centers for a million population. They found that despite the relative abundance of trauma centers in some states, more than 1/3 of patients with major trauma are treated at centers with very low volume. This is a study from 2004 or 2005 out of Penn. 69.2% of patients had no access to a level 1 or level 2 trauma center within 45 minutes. You can see the graph on the left. If you extend that to 60 minutes, they found that 84.1 had no access. This equates to 46.7 million Americans without access within an hour, that golden hour of trauma care. And that's a problem. We need to make sure that as trauma providers, we're aware of this disparity. In stark contrast to this, 42.8 million Americans had access to 20 or more level 1 or level 2 trauma centers within an hour. This is mostly in the areas that have a very populated or urban setting. This is echoed in 2016 in the Journal of Surgery. 14% of patients had an increase in mortality for rural residents across America. This, again, underscores the concept that there's a disparity in rural America for access to trauma care. In 2009, Eastman did a Scudder oration at the American College of Surgeons. He showed this graph, which shows adjusted annual death rates for motor vehicle traffic deaths in 2000 to 2006. If you overlay this on another graph of areas where surgeons are available for trauma care, we actually find that the blue areas have access to trauma centers within 60 minutes. And we find that the areas of highest injury and death rates are completely opposite of that, greater than 50% mortality rates. Long travel times equates to high death rates, and as a consequence, this underscores again that we need to be addressing the disparity of trauma care in our rural America. This is again echoed in other studies and showed that as you extend drive times for rural residents, the increase in mortality is 21%. I'm going to switch gears now to our trauma system in Delaware itself. We have a very unique system. It's something that's to be marveled at for the efficiency that it's been developed. A couple numbers for you. In Delaware in 2015, we had 7,900 injuries requiring hospitalization, with a resultant 361 fatalities from injury. There were 24,066 motor vehicle collisions, with 133 fatalities from this, and 8,000 injuries, resulting in $641 million from traffic injuries alone. This is our trauma care system as it is in Delaware right now. We actually have 6 trauma facilities, 6 level 3, and 1 level 1 center if we accept our PED center in AI DuPont. I also comment on the use of helipads, and you can see the Christiana-operated Life Flight helipads marked on the right side of the graph. The Delaware trauma system was realized as a joint effort through both legislative as well as healthcare personnel. The Delaware Office of Emergency Medical Services in 1993 started the process of a statewide trauma system plan and then drafted legislation for this. In 1996, the trauma system legislation was passed and regulations were enacted in 1998, and the system was inaugurated in January of 2000. This is some data from somebody that we know very well, published in 2007. The impact of level 3 trauma centers was assessed, and they actually found that there was an improved mortality at these level 3 trauma centers from an inclusive trauma system. This impact was 5.3% down to 2.8%. They also found that there was an increased interfacility transfer rate within the state of Delaware, but again associated with an impact in mortality for these level 3 centers. Looking forward, they actually assessed our trauma system as a whole from the inclusive policy, and they actually found an incremental mortality decrease from 45.7% in 1998 down to 20.5% in 2007. This rate of decline was in stark contrast to the rate of decline noted in the National Trauma Data Bank, and we had an improvement faster than the national average from our inclusive trauma system. And I think something that underscores the efficiency of what we are working with here at Christiana Care and in the state of Delaware as a whole. On the whole, in Delaware, injury continues to rise. We see a steady incline in the amount of injuries noted in the state as a whole. However, we've maintained, if not improved, our mortality rate, especially in contrast to the National Trauma Data Bank. So we are doing a good job in the trauma care here in Delaware. This is a synopsis of the 10 most frequent types of injury resulting in hospital admission for 2015. We see that falls heads the list, 20% fall from standing, and motor vehicle collisions are one of our next biggest sources of injury for our patients. This graph is designed to show you that we have a fair number of falls in our elderly patients, and we have seen this inclining throughout the course of the last couple of years. and we need to be aware of the burden of this disease as it relates to our trauma system. We've actually ongoing research efforts in our trauma department centered around topics related to this type of injury and are aware of the public health impact that it has in our trauma system. However, we need to also be aware of other burdens of disease that we experience. This is the number of violent crimes in the city of Wilmington, and we can see that even as relates to last year, we have an increased number of violent crimes even at this point in the year with a couple months left to go. In contrast to the age burden associated with falls, the age burden of assault injuries is actually much lower in the younger years of life. And as we've seen, the burden of financial impact on this is actually going to have a much higher course. This is usually due to firearms. However, the system is inclusive for all the types of injuries that we see. So again, I just want to underscore the themes that we see again, that trauma is a public health issue and has a significant impact on the mortality and the morbidity of our patients. That we need an inclusive and integrated trauma system for the optimal care that's centered around the unique needs of our particular region. And that this implementation of a successful trauma system requires leadership and coordination so that we can accurately deal with the burden of this disease. I think we need to make sure that we are providing the voice to our patients that have no voice so that we can accurately take care of our patients in the system itself. Moving forward to the future of trauma, I'd like to comment on a couple of different topics evident throughout the literature. In 2001, there was a study in JAMA that actually compared high and low volume centers for trauma care. Two different disease burdens that they looked at. One was penetrating abdominal trauma with shock. And they actually found that high volume centers had a statistically significantly decreased odds ratio for death, 0.02 in their trauma patients with a high volume. This actually, the inflection point was about 650 patients in that trauma center per year. In addition to that, if you look at multi-system blunt trauma, in patients with coma, they actually found that that same inflection point held true. 650 patients had an odds risk of death of 0.49 compared to low volume centers. I think this bears through along with improved length of stay as well and underscores the need for appropriate care in high volume centers so that we can accurately and correctly take care of our trauma patients. Another study out of 2014 in Jacksonville underscores another concept, and that is the development of other systems within a state and region of care. In 2010, there was a Level 2 trauma center that was established in close proximity to the Level 1 center in Jacksonville, Florida. The Level 1 trauma center found a reduction of 3.7% for their trauma patients within the first year of implementation of the Level 2 system. This inclined to 9.4% the following year. They actually found a reduction of AIS scores for head, chest, and abdomen with this as the Level 2 trauma center was able to care for these patients. However, they found that the increase in expense necessary was 217% for the system as a whole. And however, they did find that the increase in the trauma center access was 25% for their system. Two concepts with this. First, that you will increase access to care by development of a Level 2 trauma center associated with that. However, the cost of care and the impact on the volume of their center was significantly impacted. And I think that this comments on that we need to reduce the burden of trauma care disease, but not at the expense of the volume of the trauma system that drives care in that region. This is a study published at Pittsburgh in 2017. They actually looked at the distribution of MVCs in Pennsylvania with some very interesting technology, and I think we're at the crossroads of where imaging or technology is going to take us as we develop trauma care systems. They mapped Pennsylvania trauma resources interposed on a map of MVC-related fatalities. You can see the red dots are centered around hot spots of trauma mortality related to MVCs. The blue dots are helipads as well as trauma systems, level 1 and 2. They looked at a linear regression model, and they actually found that MVCs were associated at 10 miles from a trauma center had a steadily increasing level of mortality. They actually also found that if you put helipads at these areas of high mortality in the state, they had a 12.3% reduction in overall mortality for their system through some statistical analysis. And again, I think we need to be looking to technology to try and optimize our system of care. Gone are the days where we implement things and see how we're doing. We're trying to look at preventative care for our trauma patients and things that we can impact for the mortality of our system. Another system that came out with this was Scotland. They actually mapped the entire area of Scotland for all of their systems that could become trauma centers. The red are areas of level 1 trauma centers. Blue is potential level 2s, and green is level 3s. They applied triage criteria as well as application of drive and flight times to their program designed for geospatial analysis. And they configured a system of care that was designed to provide appropriate volume to their facilities as well as appropriate triage and timely transport of their trauma patients. They actually came up with a number of configurations that would work within the system. They actually found that one major trauma center, one level 1, would suffice with a high volume, or they could have moderate volumes with 2 level 1s and a multitude of level 2 trauma centers. I think this informs decisions about how we can optimize trauma care for our patients and trauma system planning and development as it relates to the future of trauma care. And we can apply this to the United States as well. I would be remiss to talk about the future of trauma care in the United States without discussing this document. This was released in June of 2016. We found that lessons learned from military combat theaters and preventable death have not been translated appropriately here in the United States. Certain combat teams have actually noted the ability to maintain a 0 preventable death rate within their trauma system in the military combat theater, and we have been unsuccessful in doing so up to this point. A joint task force utilizing multiple different healthcare and governmental agencies was tasked with this initiative, and this is a very aggressive plan designed to have 0 preventable deaths in the civilian theater. I think it still remains to be seen what this will mean for the future of local as well as national healthcare, and I think that we can comment on the impact that this will have as it develops in the United States. So going back to the initial analogy, I think that the way that we lead our target, the way that we are going to impact the trauma system as an evolution, is to be leaders in and of itself. The goal of a trauma system is to constantly change and transform to the best possible outcome. As healthcare in the United States continues to evolve, it's not always in a way that allows for the optimal care of our trauma patients. Multiple studies throughout multiple specialties have commented on disparities in healthcare through the delivery of multiple different reasons. And I think that leading the list of disparities should be that fragmented systems of trauma care with poor access to rural residents. The impact of this disease is not unrecognized, as I've shown you, and that this should be consistent with the level and the burden of trauma care in the United States. Christiana Care is the leader of our system. We need to be the advocates for our patients. We are the level 1 trauma center for our state, accepting pediatrics. We are involved in much of the process and quality improvement in this state, which centers around trauma care. We are the only site which trains surgical residents in the state of Delaware, and it's up to us to champion the cause of optimal care for our trauma patients through both example and voice. The development of a trauma system will only further develop our hospital system as a whole into a more highly functional system that's capable of dealing with anything that goes through the door. So how are we to lead the target in the future? I would call for our system to look at participation in a GIS-based algorithm through the ACS Committee on Trauma for optimal trauma system design. This will impact improved regional access for care in our system, improve cost effectiveness, and improve coordination of resources, services, and special populations for our trauma patients in our system. I would call for us to increase our educational programs to impact trauma prevention, particularly through substance abuse prevention, and we're actually already doing that in our system as a whole. This will improve the prevention of injury in our system. And finally, I would call on us to collaborate with our local military facilities for joint knowledge and training. And I would especially comment on this as it relates to disaster prevention for contingencies as we see a change in disaster management throughout the United States. This is not just for trauma. We as surgeons as a whole should be looking at surgical leadership. It's imperative in all specialties, whether general surgery, vascular, or oncology, for us to be leaders in our system so that we can impact the care of our patients. This can take many forms. This can be local leadership. This can be hospital leadership. This can be national advocacy. Just a little plug for the Political Action Committee. I will comment that only 3% of our ACS members donate to the PAC. This is a way for us to advocate for change in our system. And in addition, this advocacy requires feedback to our legislative partners so that we can understand what's happening on the ground here as they make policies for us. How do we lead? It's through the actions of the individuals such as these that we can cause progression towards a better future for trauma care in our system. It's through advocacy, through education, and through united effort that will achieve the best outcomes for trauma patients and our system as a whole. I'd like to extend a thank you to Dr. Kevin Bradley and to Dr. Mark Zapoli for their help in this presentation. And I'd like to thank Christiana Library for their assistance in the research for this talk. And I'll take any questions at this time. Thank you very much.
That was outstanding. Dr. Painter, thank you for that. Questions from the audience? I would think that this topic is ripe for the picking for questions. Of course, Dr. Spaulding.
All right, Dr. Painter, that was, am I on? That was an outstanding review of trauma system. I have a couple questions.
Yes.
So if we subject Delaware to a geographic inspection and they say, you have too many level 3 trauma centers, what are you going to do?
I think that's the question. So our system is unique. We have an inclusive system. The level 3 trauma centers function, and we've seen the impact that they have from the educational component that we implemented back in 2000. I think that the geospatial analysis can be used to inform how we develop our system. We don't necessarily have to implement the changes that it states, but I think that we can use it to optimize care. It's not just about optimal trauma care delivery, it's also about cost effectiveness. And as we see, there is a disparate amount of funding available at the state and the national level. So we don't necessarily have to say just because level 3s should be cut out of our system for optimization of care, we need to do that because they provide a role and a service to us. However, if we're going to be good stewards of the money that we have available for trauma care, we have to consider that maybe we're not using that money appropriately and decide using our legislative partners how we can best allocate funds and how we can best allocate trauma care.
Okay, money. So the two graphs you showed about funding, of course, hopefully everyone in the room noticed that Delaware was white.
Yes, it is.
We have no state funding. You're now able to go in front of the Delaware legislature to ask for state funding. Make your pitch.
I would say that we've seen the power of our Delaware system. This is an inclusive system. It is a standard for trauma care both locally in our state as well as nationally, and we've seen the impact that we've had in our system. We know the public health burden of trauma care in our system and that we need to have an impact on that. If you are going to state that trauma is a public health issue, how can you deny the funding necessary for us to have an actual impact in that design? That is sending a mixed message and a message that is in stark contrast to how we should be caring for our patients. If you're going to say that this is a public health issue, you have to provide the resources for the care of our patients.
Mark, can we bring him down to Dover with us? I think that your whole PowerPoint points to the issue. Disparity of distribution is alarming. Disparity of funding is alarming. And then what Dr. Rhodes talked about, the tsunami effect of what's coming at us now and what we'll see in the future. We're becoming saturated.
Yes, sir.
Right? We have over 4,000 trauma activations. The elderly amount is increasing. That's a burden to our health system. And what that one slide, it's probably mid-presentation, the unintentional injury and years lost, that's also not being tracked effectively in terms of post-injury convalescence.
Yeah, absolutely.
And years lost from life and productivity for everyone. Dr. Tizzi had a comment.
So I have an interesting question. So you said that motor vehicle accidents are responsible for the majority of trauma outside of falls. So you had 24,000 of those in the state of Delaware. Today, the technology exists for autonomous vehicles, and even if we only have 5% of people who adopt them within 10 years, that number will effectively go to almost zero. Certainly, serious injuries will disappear in America within a very short period of time. I know many people think it's far away, but it's actually not. And those patients are generally insured either through auto insurance or if you have a car, you have some type of health insurance frequently. And those fund a lot of trauma systems, maybe smaller ones more so than the larger ones. Do you think, what kind of impact, I mean, you use this fancy algorithms to say, well, we need to put trauma centers here, there, but that's based on current issues and problems, how is that going to affect trauma systems, trauma training in the future when that won't represent the majority of what you see in 20 years?
No, I agree with you. I think the technology is moving at a pace that we're going to struggle to keep up with. I think we're going to see a further disparity noted with that, as you said, through changes in funding for that. I think that, again, it's up to us to advocate for the optimal care of our trauma patient. I think it's up to us to consider innovative solutions to this. We can also use technology to impact trauma care. We already have systems in place to allow for remote access to trauma through different communication techniques. We can utilize those to impact trauma care if funding for lower-level trauma centers were to go away. I do not think that the motor vehicle collision burden will completely go away. I think it will significantly reduce, as you say. I think that, too, we will see that trauma care will change to falls, will change to violent crime, and it's still going to be an impact. I think the bigger problem that we're going to see is that trauma care providers are actually going to have a lower level of training to deal with traumatic injuries. I think also we're going to see lower levels of trauma fellow training is going to impact the system for the care of trauma patients as a whole. And I think there are disparities in the surgical workforce, both on the general surgical level as well as the trauma level. They're going to impact our system in a much bigger way as that evolves.
Don't worry, Dr. TC, there will always be guns.
I don't know where to go with that one. Any other questions or comments for Dr. Painter? Dr. Chaudhry in the back.
Excellent talk, Dr. Painter, and very informative. Loved it. In Delaware is great, but looking at the national trend, if I saw correctly, you said trauma cost was $800 billion.
$820 billion, yes, sir.
$820 billion, and trauma represented or injury represented roughly 20 to 25% of like cardiac disease to healthcare, right? So heart disease costed the same amount as trauma, but is 20 to 25% of the healthcare burden. Why do you think that disparity is? Why is trauma costing so much? Is it because of allocation of resources? Where time to get there? Is it delay in diagnosis or treatment, or is it actually like too much testing? Where is this cost, and is there room for improvement there?
So the systems in and of themselves have an inherent cost. It costs money to run emergency medical services providers in the pre-hospital phase. It costs money to have the communication resources necessary. It costs money to care for the patients in the hospital itself. Your comment about the workup for our trauma patients, yes, that is a potential area for improvement, but I think it's the minority. I think that if we utilize our resources more appropriately, we're going to have a more efficacious impact on cost effectiveness in our system as a whole. The comment is made mostly to show you that the burden of trauma disease is extremely high and not to be underestimated. So, and I think that's the take-home point that I want you to understand for this.
Ideally, the best system is one that gets the right patient to the right place in the right amount of time. You can see clearly nationally we haven't met that objective yet.
Not yet.
Okay. Dr. Giberson.
Matt, can you just clarify, because I think there could be some misunderstanding about what was just exchanged there. The $800+ billion annual cost isn't actual money going to trauma care. It's the cost to society, probably the majority of which is from loss of productivity.
Correct, yes, I apologize. That is years of life lost. That's the economic impact of the economic workforce that's being lost to this. It's the cost to society for rehabilitation of these patients and the disability costs associated with that. It's not just the hospital-associated costs in the trauma system itself.
Nonetheless, we get where you're going with that comment, Dr. Chaudhry, that we need to look at cost containment within each individual center.
Correct.
And I think our downstate colleagues at some of our level 3 centers have recently expressed concern over overuse of CT scans.
It's another topic for another day. We could spend an hour talking about that.
So meaningful use of CT, meaningful use of blood, meaningful use of consultation, all of which needs to be looked at within an individual trauma center.
Absolutely, and interfacility transfer as well along with that. Yeah.
Correct. Yeah, absolutely right. That's another topic. Pretty hot topic.
Yes,
Dr.
sir.
Chaudhry.
Sorry, just to follow up. Thanks for the clarification, Dr. Giberson. And so that helped. The other thing, that was interesting is when you mentioned in Florida they had a level 1 trauma center and they added a level 2, and the cost was more than 200%, right? So,
Correct.
And the impact was only 25% improvement. So, that's why is it the people getting to the right place?
I mean, you're going to increase access to care, and that's ultimately, if you're looking at trying to prevent death, rather, in a trauma system, you have to have improvement to access to care. I think that's one of the biggest disparities that we see. Not along with that, though, is the concept that we don't have the money to care for trauma patients within the system as it exists right now. So you have to balance access to care with the cost effectiveness of the system. And if you're only, as you said, getting a 25% increase in access to care at a 200% margin, that's not adequate utilization of cost effectiveness.
Just a comment that a paper you need to include in your talk is a paper written by Dave Ciesla, trauma director at Tampa General, who just updated this Florida concept. This continues to happen in many states, Florida in particular, where the for-profit hospitals are moving in, establishing level 2 and 3 trauma centers, and are affecting in a negative way the care of the Floridians. And it was a lead article in the Journal of Trauma a couple months ago. So
Correct, absolutely.
Florida continues to feel this.
Dr. Jadali and then Dr. Sixton, and we're going to close.
Matt, I heard that doesn't do. Here? Better?
Yes, sir.
So the cost that you mentioned about making a new trauma system or trauma hospital is mostly related to the level 1 centers that you are referring to. And making it level 3 is not associated with same amount of cost that you are referring to. The most important thing that is everybody talks about, right patient, right time, right place. That is making a level 1 trauma center in the middle of North Dakota. It's not going to be costly, and it's going to add significantly higher amount of money that you have to place there for the amount of patients. But finding a level 3 that can evaluate the patients and transfer the patients, as you showed, it decreases the amount, it still decreases the mortality and better money spent. So that is an important part that we all talk about the level 1s and less about the levels that are coming down. Level 1s are very, very important more than anything else to collaborate and make the system running efficiently. And that has to be done that way.
I agree with you. I think that to overlook the lower level trauma centers is to do ourselves a disservice. We already know that we're not going to have enough trauma care providers in the future. We have to engage our general surgeons in the community to be able to function in these level 2 and level 3 trauma centers that don't have quite as many resources as the level 1. However, there is a cost associated in the trauma system of having all of these facilities in a system in and of itself, and that cost is shared by the system as a whole. To ignore even a small component of the system is to ignore a potential area of cost effectiveness as well as the triage of our patients. So I'm not saying we need to close all level 3s or close all level 2s. I'm saying we need to accurately assess where is the burden of disease, how can we impact that disease effectively, and what's the most cost-effective strategy to make sure that that right patient gets to the right place at the right time.
Dr. Sixta.
Dr. Branner, that was just amazing. I think your literature review for this is phenomenal. I'm not sure that you could have packed much more into this. You did a really excellent job.
Thank you.
I'm just curious, did you come across anything with the correlation of trauma burden and the opioid epidemic or polysubstance or alcoholism or anything like that?
Absolutely.
It's like a whole other talk, I'm sure. But
you could have taken this talk about 5 different ways at the end, and I chose to focus on disparities in care in the rural setting, as well as the economic impact that has. You could talk for, again, another hour about the substance abuse burden. Actually, if you look at our Delaware system, there is actually data that shows that the area that we can impact is the area of substance abuse. We actually do a decent job at seatbelt prevention in the state of Delaware for motor vehicle collisions and helmet laws for motorcycles. However, about 20% or more of people that are involved in MVCs or MCCs actually have a substance abuse problem associated with that. So if we're going to have an impact in our system further, I think that's the next step forward, which is why I comment on it.
I just thought it was curious as I was driving to work this morning. I follow that sign. Anybody who's coming up 495, it says, or maybe it's 95, 495, at like 92 deaths this year for fatalities for MVCs. And I've been watching it all year as it climbs. I'm thinking, hey, we're doing a pretty good job. It's not even December yet. But your numbers up there for penetrating trauma for GSWs, was it 171 fatalities this year? Is that what you had?
It was 179, I think, incidents and about 20-something fatalities. I mean, if you look at, in comparison, it's a smaller volume, but it's not an insignificant volume. So we have to be aware of the association of substance abuse as it relates to our impact in motor vehicle collisions, as well as it relates to violent crime. And it's a big impact. It's a big burden in our state.
Again, thank you, Dr. Painter. You know, if you want, you should try and publish this as a review article about history, the military, and how it impacted the formation